All right, let's get right into it. Today, we're going to talk about one of the most powerful diagnostic tools we have, but one that's honestly often overlooked, the peripheral blood smear. We're going to focus on what it tells us about disorders of granulocytes and monocytes, the frontline soldiers of our immune system. So let's start with what you can learn from just a single drop of blood. Just look at this. It's amazing, right? In that one tiny drop of blood, spread out on a slide, there's a whole universe of information. I mean, it's not just a bunch of cells. It's literally a visual story of your patient's health. You can see signs of inflammation, infection, even inherited diseases, all just waiting for you to read them. So here's the big question. Do you actually know how to read its secrets? For anyone in training, this is such a fundamental skill, and that's exactly what we're here for. This explainer is going to be your guide to decoding all those clues so you can go from just seeing cells to really understanding the story they're telling. Okay, first things first. Before you can spot what's wrong, you've got to be an absolute expert on what's right. So we're going to start by establishing a baseline. Let's meet the key players here, what I like to call the immune patrol, and see what they look like when everything's going according to plan. So these are the guys we're focusing on today. You've got your granulocytes, that's the neutrophils, eosinophils, and basophils, and then the monocytes. Think of them as the first responders of your immune system. They're all types of leukocytes, or white blood cells, and they are absolutely essential for fighting off infections and dealing with any kind of tissue damage.
Okay, I love this slide because it really connects the dots between textbook theory and what you see in the clinic. On the left, you've got the schematic, right? The whole journey of a neutrophil in the bone marrow. It starts as a simple myeloblast, goes through all these stages, promyelocyte, myelocyte, and then bam! On the right, you see the final product, that powerhouse cell with the funky, multi-lobed nucleus. Knowing this whole process is so important because it helps you recognize when things are going wrong, like when immature cells start spilling out into the blood when they shouldn't be.
So what does this powerhouse actually do? Well, the neutrophil is your #1 bacteria killer. Seriously, it's the most abundant white blood cell you have, and its whole job is to hunt down, gobble up, and just destroy any invading bacteria. That process is called phagocytosis, and neutrophils are the absolute masters. Whenever you see a lot of them, you should be thinking acute inflammation. Of course, the neutrophil isn't a lone wolf. It's part of a team. Here, you can see the rest of the patrol. See that big guy labeled M? That's a monocyte, with its classic kidney bean-shaped nucleus. And the ones labeled E? Those are eosinophils, packed with those really bright pink granules. You'll see those pop up in allergic reactions or parasitic infections. And then there's B, the basophil, the rarest of the bunch, full of those dark purple granules. Being able to tell these guys apart is crucial for getting the full picture. All right, so we've got our baseline of what's normal. Now, let's dive into what happens when things go wrong. Sometimes the first clue isn't how a cell looks, but just how many of them there are. This brings us to what we call quantitative disorders, which is really just a fancy way of saying you have a problem of numbers, either too many cells or not enough. When it comes to neutrophils, there are two big words you need to know: neutropenia and neutrophilia. It's pretty simple. Neutropenia means you have too few neutrophils, and that's dangerous, right? Because it leaves your patient wide open to infections. On the other hand, neutrophilia means you have too many, and that's usually a red flag that the body is already in a fight against an infection or some major inflammation. So you get a lab report back, and you see neutropenia. What's going through your head? Well, this table gives you a great framework. You got to ask yourself a few questions. Is the bone marrow, the factory, just not making enough? Maybe because of something like chemo? Or are the cells being destroyed too fast out in the body, maybe by an autoimmune issue? Or are they just hiding out, stuck to the sides of blood vessels? These are the big buckets you need to think through for your differential diagnosis. And what about the flip side? Too many neutrophils, or neutrophilia. The classic cause, the one everyone thinks of, is an acute infection. The body just sounds the alarm and releases a flood of neutrophils from the bone marrow storage. But it's not always infection. Things like steroids, major stress, or even just intense exercise can also make the count shoot up, basically by knocking neutrophils that were just hanging out on the vessel walls back into the bloodstream. Okay, now for the really cool stuff, the subtle clues. What happens if the cell count looks totally normal, but the cells themselves just aren't working right? These are what we call qualitative disorders.
And this is where your own eyes, your ability to spot weird shapes and structures, what we call morphology, becomes absolutely critical.
And this quote just says it all, doesn't it? The cell count can lie, but the morphology often tells the truth. An automated machine can spit out a number, sure, but it can't tell you that the neutrophils look weird or that there's something strange in the cytoplasm. That's your job. Looking at the cells reveals what's really going on.
So to make this a little easier, we're going to use a simple but really powerful framework I call See This, Think That. I'll show you a classic visual clue on the smear, and we'll connect it directly to a specific diagnosis. The whole idea is to build these instant, rock-solid visual associations. All right, first one. See this? You're looking at a neutrophil, but instead of the usual 3 to 5 lobes in its nucleus, it's just got 2. It kind of looks like an old-fashioned pair of eyeglasses, right? Think that. This is the classic look of Pelger-Hewitt anomaly. Now, here's the key part. This is a totally benign, inherited thing, but you have to recognize it because otherwise you might mistake it for a left shift of immature cells, which would make you think there's a serious infection going on when there isn't.
Okay, now this next one is, wow, it's really dramatic. See this. You see these absolutely giant, obvious granules inside the neutrophils and other white cells. When you see this, you have to think that Chidiac-Higashi syndrome. And unlike the last one, this is not benign. This is a very serious genetic disorder where the cell's lysosomes don't work, leading to terrible infections, albinism, and neuroproblems. This single visual clue on a smear points to a major, major disease.
Okay, let's zoom in a bit. See this. Look closely in the cytoplasm of this neutrophil. See that little pale blue-gray patch? That's called a Dole body. Think this. This is a sign of a major systemic inflammatory or toxic state. Now, it's not specific for any one disease, but it's a huge red flag that your patient is under serious stress. We're talking severe infection, sepsis, major burns. When you see these, you know you're dealing with a very sick patient.
So what about a disease that you can't actually see on the smear? I know, it sounds tricky, but this one's super important. It's called chronic granulomatous disease, or CGD. The weird thing is, the neutrophils look totally normal, but functionally, they're broken. They can swallow bacteria just fine, but they can't make the bleach, the reactive oxygen species, that they need to actually kill them. It's a critical diagnosis to keep in your back pocket for any patient with really severe recurrent infections.
Okay, so we've looked at problems with numbers and problems with how the cells work. The final step is putting all those clues together. It's like being a detective. You take the visual evidence from the smear, combine it with what's going on with the patient, and you solve the case. This table does a great job of tying everything together. So for CGD, you're looking for a patient with recurrent infections and granulomas, and the root problem is that NPDH oxidase enzyme. For Chidiac-Higashi, the big clues are infections plus albinism, and that's all because of a defect in cell trafficking. And then there's leukocyte adhesion deficiency. A classic sign there is a newborn whose umbilical cord is late to fall off, all because their neutrophils can't stick to blood vessels properly to get to the site of an infection. So, if there's one thing you take away from all this, I hope it's this. Looking at a blood smear is not just about looking at lab data. It's a real clinical skill. Seriously, think of it as an extension of your physical exam. It's a direct window into your patient's physiology, and it's the bridge that connects what's happening way down in the bone marrow to what you're seeing right there at the bedside. And that leaves us with a pretty big question for the future, right? We're heading into an age of AI and automation in diagnostics. And yeah, a machine is going to get really, really good at counting cells. But will it ever truly replace the trained human eye? Can an algorithm spot a subtle dolly body and connect it to the story the patient is telling you? It's something to think about. Will our eye for detail become more critical or less? Thanks for joining me.